Hi, my name is Shellen Lee, and today I will be discussing orthopedic procedures, particularly radiographs of the shoulder. And the shoulder exam is considered to be one of the top 5 radiographic procedures where the staff at UNC facilities are most often making errors either from positioning, patient safety, or image quality malfunctions. This learning module will explain how to thoroughly and successfully complete a shoulder radiographic exam in order to avoid these types of errors. This diagram shows the fundamental anatomy of the human shoulder, including the bones that make up the shoulder girdle as well as the muscles. The clavicle and scapula are the bones that make up the shoulder girdle and allows the humerus to attach. These are the bony structures to look for on a shoulder radiograph. Thus, it is important to recognize and pinpoint where these structures are located. This slide shows all the different projections that can be obtained for shoulder radiographs, with some exceptions if you have trauma patients who cannot be positioned for certain procedures. Then modifications can be made. The usual protocol includes an anteroposterior or AP projection, with an AP oblique projection, posterior-anterior or PA oblique, and an axillary view. Some outpatient clinics, such as UNC Carolina Point, requires two of the Grashey views, one with the patient internally rotating his arm and another one with the patient externally rotating his arm. This is to open up the glenohumeral joint for the AP oblique images. This slide shows the different IR sizes required for shoulder radiographs, along with their source to image distance length. An AP shoulder image requires a 10 by 12 inch IR in crosswise position at 44-inch SAD. An AP oblique projection requires an 8 by 10 inch IR in crosswise position at 44-inch SAD. A PA oblique projection requires a 10 by 12 inch IR in lengthwise position at 44-inch SAD. The axillary projection requires a 10 by 12 inch IR with a grid and crosswise position at 40-inch SAD. Let's talk about the AP shoulder projection. You're going to have the patient either standing upright or laying down supine on their back on the x-ray table. The patient's arm can be either in neutral rotation, external rotation, or internal rotation. If it is in neutral rotation, the arm is just going to be in resting position with the epicondyles at about a 45-degree angle to the IR. If the patient's arm is rotated externally, the arm is going to be rotated until the epicondyles of the humerus are parallel with the IR. If you're going to have the patient have their arm rotated internally, the arm is going to be rotated until the epicondyles of the humerus are perpendicular with the IR. The central ray is going to be perpendicular to the IR at all times, and it's going to enter about an inch below the coracoid process. For the AP shoulder image, you want to include the acromioclavicular joint all the way to the sternoclavicular joint. And you want to include the entire scapula as well. Okay, so what would be reasons for repeat of an AP shoulder? The 3 different positioning of AP shoulders are shown below, with the patient having their arm in external rotation, internal rotation, and neutral rotation. When you're evaluating the film for the external rotation, you want to make sure that the film demonstrates the greater tubercle in profile on the lateral aspect of the humerus. Also, you want to make sure that the lesser tubercle is superimposing the humeral head. You want to make sure that the coracoid process, acromion, AC joint of the clavicle, glenoid cavity, and the upper shaft of the humerus are all shown. For the internal rotation image, the lesser tubercle is seen in profile on the medial aspect of the humerus. The greater tuberosity is going to be superimposed on the humeral head. And for neutral rotation, the humeral head may appear kind of like a cotton swab. It has a very rounded head, and both the greater and lesser tubercles are partially superimposed over the humeral head. These are all characteristics to be looking for on your images, and if they are not shown, then you will most likely need to repeat the image. Alright, now let's talk about the AP oblique projection, which is also known as the Grashey method. You can have the patient either standing upright or laying down supine, and you want to rotate the patient so that they are at about a 35 to 40 degree angle and that the affected side is closest to the IR. The scapula, or the body of the scapula, is going to be parallel to the IR. The central ray is going to be perpendicular to the IR, and it's going to enter 2 inches medial and 2 inches inferior to the superolateral border of the scapula. Something that's optional is that you can have the patient rotate their arm internally or rotate their arm externally. It's part of the protocol at UNC CP2 Ortho Clinic to have the patient rotate their arm internally and externally and keep it at neutral rotation for the Grashi method. It really depends on the facility that you work at. Alright, so what would be the reasons for repeat of an AP method image? The whole goal is to see an open joint space between the humeral head and the glenoid cavity, also known as the glenohumeral joint. As you can see, the image on the left shows a clear open glenohumeral joint, and the image on the right shows a closed glenohumeral joint, and you can see that the head of the humerus is slightly overlapping the scapula. So the glenoid cavity should be seen in profile. So if you were to get the image on the left, it is acceptable, and the image on the right is unacceptable. You would have to repeat the image on the right by either rotating the patient more towards the board or less towards the board to try to get that joint open. And you have to be mindful that every patient body is different, and pathology could make everything more confusing, so you'll have to kind of get more experience and know how to open up that glenohumeral joint. Now for the PA oblique projection, also known as the scapular Y view, you can have the patient upright or recumbent. The patient is going to be rotated about 45 to 60 degrees until the scapula of interest is perpendicular to the IR. The central ray is going to be perpendicular to the IR, and it's going to enter the medial border of the scapula right around the level of the scapulohumeral joint. So for the scapular Y view, you want to take the exposure on suspended respiration, just to minimize motion and blurriness. But what would be some reasons for repeat? The anatomy that you should be seeing would be the humerus, the coracoid process, the acromion, and the body of the scapula. And we call it the scapular Y view because the image looks like a Y because the side view of the scapula body, acromion, and coracoid process make up a Y shape. Normally, the humeral head is going to be superimposed over the junction of the Y, as you can see on the bottom left corner very clearly. The image is good for demonstrating either an anterior or posterior dislocation of the humeral head. So in an anterior dislocation, the humeral head is going to be seen below the coracoid process, and in a posterior dislocation, the humeral head is going to be seen below the acromion. So you just want to make sure that you can see all of these vital characteristics, and if the patient tells you that he has a dislocation, you want to be on the lookout to see if there is anterior or posterior dislocations. The axillary view, also known as the Lawrence method, the patient is going to be supine with the IR in a crosswise grid. The IR in the crosswise grid is going to be close to the patient's neck, and the patient's head is going to be turned away in the opposite direction. You want to keep the shoulder and elbow of interest elevated about 3 inches from the table to keep it boosted. The patient's arm is going to be abducted about 15 to 30 degrees, and the hand is going to be supinated. But you want to be mindful if there are any fractures on the arm or shoulder that the patient could have. The central ray is going to be horizontal and perpendicular to the IR, and it's going to enter the axilla. Alright, so for the Lawrence method, the anatomy that you should be seeing is the proximal humerus, the scapulohumeral joint, the AC articulation, and the coracoid process. If these anatomy are not shown or are clipped, then you must repeat the image. And you can see on the left image that is demonstrating the Lawrence method, and on the right image is actually demonstrating a modification of the Lawrence method called the Roffert method, and it's basically when the patient has a Hill-Sachs defect and we want to demonstrate it. So you want to set up the patient exactly as the Lawrence method, but you're going to be rotating the arm externally until the hand forms about a 45-degree oblique angle. And like I said, it demonstrates the Hill-Sachs defect, which is basically like a wedge-shaped compression fracture on the articular surface of the humeral head. So this type of fracture may occur when there is an anterior dislocation of the humeral head. The white arrow is pointing to where the Hill-Sachs defect is, and these fractures occur on the posterolateral aspect of the humeral head. All right, to sum things up, here's an overall view of why technologists make repeats. The important and necessary anatomy must be demonstrated. So for example, if certain joints such as the glenohumeral joint is closed or the scapula is not seen in profile, then these are all reasons as to why images must be repeated in order to get that perfect angle and that open joint. Because that's the whole point of taking these images. And that's one of the main reasons why technologists often have to repeat these images, because every patient is different and you have to think about how you can angle the patient or how much to turn the patient towards the board or away from the board to get that necessary anatomy to be shown on the image. There are some image quality errors that could happen due to not enough penetration, or there being a lot of scatter, or the grid not working as you want it to work. But these errors are not as common as positioning, and there can be some patient safety errors if your patient is a trauma patient, or the patient has a splint on, cast on, or has certain pathologies like arthritis or known fractures or unknown fractures. So you have to be mindful of all of these important elements as well, and make sure to get everything necessary on the image to make a good diagnosis by the radiologist. And this concludes the shoulder learning module. Thank you.